Today we'll be discussing in detail about placenta. So the outline of class is, we'll start with the placental development and discuss in brief about the normal placenta and how it appears on sonography and MR imaging. Okay, then we'll discuss the placental size and shape abnormalities. Following that, the abnormalities of placental location. This is very important. Then we'll discuss the umbilical cord insertion on the placenta, the site of insertion and its related abnormalities, followed by the morbidly adherent placenta, which has been discussed earlier, but it's a very important topic and we'll briefly revise that. Then the vascular abnormalities of placenta, non-trophoblastic tumors like chorioangiomas, and some trophoblastic tumors like GTD and the invasive ones. We'll also discuss placental membrane abnormalities and summarize our topic, the entire thing that we have studied in today's evening. So this will be the outline of class. So let's start with the development. So placental development starts when the blastocyst goes on to implant. So when the blastocyst implants in the upper uterine corpus, it contains two types of the cells. One is the trophoblast, which is the outer one, and then we have the inner cell mass or embryoblast. The outer trophoblast will help in formation of placenta, and the inner cell mass will form embryo, the amnion, and the umbilical cord. Okay, so very briefly we'll discuss the embryology. This part is the trophoblast. So the trophoblast, once the attachment of blastocyst has happened, it will divide into cytotrophoblast and the syncytotrophoblast. The syncytotrophoblast will go on invading into the prepared endometrium, which is already hormonally receptive and ready for implantation. So this is how the implantation has started, and eventually this purple thing is the syncytotrophoblast. So this will go on to cover the entire conceptus and will invade these are the blood vessels. So it will invade the adjacent blood vessels and glands, creating the lacunae, the beginning of lacunae, and then the extra embryonic mesenchyme will penetrate the villi and form secondary villi. Eventually, fetal vessels develop and tertiary villi is formed. So this is a cross-sectional image of the villus. So the fetal derivatives in placenta consist of fetal vessels and the placental cotyledons. The villi consist of the fetal vessels which are surrounded by the cytotrophoblast. So this yellow thing is the cytotrophoblast. Okay, the cytotrophoblasts are covered by the syncytotrophoblast, and the decidua then will get traversed with few villi. When the entire thing, the length of the decidua is traversed, it is known as the anchoring villi, and the rest of the villi are known as floating villi. Okay, the maternal and the fetal blood are still separated. Imagine this is the villus, and these are the surrounding area is the intervillous region. It will be filled with the maternal blood. So the exchange will happen across these layers. There will be no communication. Okay. So this was the microarchitecture. So the decidua, which is the maternal part. So we're discussing how the placenta forms. So the decidua, which is the maternal part, has three parts. The decidua paritalis, capsularis, and basalis. Okay. So in this image, you can see this part is the decidua basalis, which will contribute in development of placenta. Then we have the decidua capsularis, and this area is the decidua paritalis. So this the capsularis and the paritalis lumen, it will obliterate the uterine lumen eventually as the sac will develop. Then decidua basalis along with the chorionic frondosum will develop the placenta. Chorionic frondosum is the one which will form the chorion villi. These are these area which is going to participate in the formation of placenta is known as the chorionic frondosum. The rest one will wipe out the other half which is not participating in placenta formation, and now it is known as the smooth chorion or chorionic villi. Chorionic villi are of three types: primary, secondary, and tertiary, and now you know how they develop. And the tertiary villi can be anchoring villi or floating villi, depending on whether they are attaching to the maternal plate also. So this is a microarchitecture of placenta. So these are the villus which are going till the maternal edge. Okay, so these are the anchoring villus which are anchoring the placenta in place. And then we have few villi which are floating villi, which are going to branch upon. In the villus, you have the fetal vessels. Then we have certain cytotrophoblasts, which are known as the extravascular trophoblasts, which help in remodeling of the maternal vessels. And if this does not happen, then preeclampsia and other related complications like FGR can take in part. So this is how the vessels will become dilated, the resistance and impedance will decrease, and it will become the maternal fetal circulation will set up. This is how it happens. Now we have discussed quite in detail. So what do you want in syncytial trophoblast to be repeated? Just let me know. So this is a microarchitecture. You can read the details later on. So this is the basal plate, maternal side. Then we have the villi. The intervillous space is filled with the maternal blood, which is coming from the vessel. And this is the chorionic plate, which is formed from the fetal part. Okay? So this is the placenta, how it is. And the main crux of discussing for 10 minutes is that how the circulation happens. So from the maternal vasculature, the oxygen-rich RBCs come into intervillous space, and then this blood will contact your terminal villi. So this is terminal villi, and the blood is contacting this region. Oxygen will diffuse across the layers, and the fetal erythrocytes will take part in this and will take the oxygen. Then these fetal capillaries will then join together and form merge into larger fetal vessels. Okay. Then the oxygenated fetal blood will drain into the umbilical vein and will go on to the baby. So blood will go to the baby, the oxygenated rich blood, and then same way it will come back. So the oxygenated blood is also going, and the waste products and other products are being excreted out similarly. Right. So this was embryology. If you have any doubt, you can let me know at this point of time. Now we'll start with the radiology. So the checklist for doing an ultrasound for placenta. You are doing ultrasound for the entire baby, but placenta is something which is just limited to being the location. You just specify the placental location and whether it is above the os or not, and that's it. The placental evaluation stops there. But the evaluation of placenta is lot more.
आपकी वीडियो स्टक हो गई है.
Okay. अभी चल रही है?
नो मैम, स्टक हो गई है एक जगह. हाँ मैम, अब ठीक है.
ठीक है, thank you. So this is the checklist. Checklist for evaluation of placenta. Okay, thank you. So when you are evaluating the placenta, now I'll slow down. So when you're evaluating the placenta, we'll start with evaluating the morphology of placenta. Placenta is typically discoid and has rounded margins. Okay. The variations or abnormalities include subcentriate placenta, or if the two lobes are symmetrical in size, bilobate or bilobe placenta. Then we have this extrachorial placentation, circumvallate placenta, and the membranaceae. So these are the variations, and they have some related abnormalities or associations with them. Then you measure the thickness of placenta. The placenta is typically 2 to 4 centimeter in thickness. Okay, and it will correlate the millimeters of the placental thickness is going to, if you see in cross section, so this measurement in millimeter corresponds to the period of gestation in weeks. On ultrasound, the normal placenta should be homogeneous. If there is certain anechoic spaces or you have heterogeneity, it might point to some abnormalities like the infarctions, or hyperechoic areas may point to calcification. Then location, everybody says where the placenta is. It's variable. It can be anterior, posterior, on lateral walls, or fundus. Okay. Low-lying placenta, placenta previa is the ones which are causing trouble. Then we'll discuss the cord origin. You will tell where the cord is originating, from which site of the placenta, whether it is central, marginal,